In this video, we are going to dive deep into the different treatment modalities available for neuromyelitis optica, or NMO. Now, this summary frame includes all the key concepts we're going to cover, but don't worry, we'll break everything down step by step, and we will bring this slide back up at the very end of the video for a quick review. Neuromyelitis optica, or NMO, is a severe autoimmune disorder that mainly targets the optic nerves and spinal cord. NMO attacks can lead to rapid and profound vision loss, paralysis, and even life-threatening complications if untreated. Fortunately, there are now effective, evidence-based treatments available that can control acute relapses and reduce the risk of future attacks. For acute attacks of NMO, first-line therapy is high-dose intravenous glucocorticoids. The recommended regimen is methylprednisolone, 1 gram daily for 5 to 10 days. This is typically followed by a prednisone taper over several weeks, aimed at decreasing inflammation quickly and preserving neurological function. In cases where the response to steroids is inadequate, or there are ongoing symptoms, plasma exchange becomes the next step. Plasma exchange involves 5 to 7 treatments, each removing 1.5 plasma volumes per exchange, and is specifically indicated for steroid-refractory attacks. For long-term management, several FDA-approved prophylactic treatments are available for patients who are positive for AQP4 antibodies, each with a distinct mechanism of action. These include Inebilizumab, marketed as Uplizna, Satralizumab, marketed as Enspryng, and 2 complement C5 inhibitors, Eculizumab, or Soliris, and Ravulizumab, or Ultomiris. Together, these agents form the backbone of modern long-term preventative treatment for AQP4-positive NMO. Inebilizumab, also known as Uplizna, is a B-cell depleting monoclonal antibody targeting CD19. It has demonstrated a 77 to 78% reduction in attack risk in AQP4-positive patients. It is administered as an intravenous infusion, 300 milligrams at weeks 0 and 2, then every 6 months. Inebilizumab may lead to a dose-dependent decline in serum immunoglobulin G and neutropenia. It is not approved for use in AQP4 antibody-negative patients, and coverage may be difficult to obtain for these cases. Satralizumab, or Enspryng, is an interleukin-6 receptor blocker. As a monotherapy, it achieves a 74% risk reduction, and as an add-on therapy, a 74 to 78% reduction. It is given as a subcutaneous injection, 120 milligrams at weeks 0, 2, and 4, then every 4 weeks. Satralizumab requires pretreatment screening for hepatitis B, tuberculosis, and liver function tests, and ongoing monitoring for transaminase elevations and neutropenia. Its benefits do not extend to AQP4 seronegative NMO. Eculizumab, known as Soliris, inhibits terminal complement C5 using IV infusions. It has shown a 94% risk reduction. The dosing is 900 milligrams weekly for 4 weeks, then 1,200 milligrams every 2 weeks, starting at week 5. There is a serious risk of life-threatening meningococcal infections with complement C5 inhibitors, so patients must receive meningococcal vaccination before starting therapy, with repeat vaccinations at specified intervals. Ravulizumab, or Ultomiris, operates with a similar mechanism of inhibiting terminal complement C5. Recent clinical trials show complete suppression of attacks in studied patients. It uses weight-based dosing followed by infusions every 8 weeks. As with Eculizumab, there is a serious risk of life-threatening meningococcal infections, so patients must receive meningococcal vaccination before starting therapy, with repeat vaccinations at specified intervals. Both Eculizumab and Ravulizumab are restricted under a REMS program and require close monitoring for signs of infection. Alright, as a quick recap, here's a comparative analysis of FDA-approved prophylactic therapies for neuromyelitis optica. Inebilizumab, branded as Uplizna, targets CD19 on B cells and has a risk reduction efficacy of 77 to 78%. This is dosed every 6 months intravenously, with main risks including IgG decline and neutropenia. Satralizumab, or Enspryng, targets the IL-6 receptor and provides a 74 to 78% risk reduction. This is given subcutaneously every 4 weeks. Monitoring includes liver function tests, neutropenia, and screening for hepatitis B and tuberculosis. Eculizumab, Soliris, and Ravulizumab, Ultomiris, both target complement C5. Eculizumab is dosed every 2 weeks intravenously with a 94% risk reduction, while Ravulizumab is given every 8 weeks and has shown complete suppression of attacks. For these drugs, the major safety concern is meningococcal infection risk, requiring enrollment in a REMS program for monitoring. In certain situations, off-label or empiric immunosuppressants are considered. Mycophenolate mofetil is used, typically 1,000 milligrams twice daily, especially in AQP4 negative patients or before trying FDA-approved options. Rituximab, a B-cell depleting antibody, is another choice, delivered as a 2-gram IV dose every 6 months. Historical regimens also combine glucocorticoids with azathioprine, which starts at 2 milligrams per kilogram per day after an initial steroid course. Notably, some drugs commonly used for MS are ineffective or even harmful in NMO. These include interferon beta, glycerimer acetate, fingolimide, natalizumab, and alemtuzumab. Use of these agents may increase the risk of NMO relapses, underscoring the critical need for accurate diagnosis and selecting the right therapy for each patient. There are also investigational therapies being explored for treatment-resistant NMO. One promising approach is anti-BCMA CAR T-cell therapy, where a patient's own T-cells are engineered to specifically recognize and attack BCMA-expressing plasma cells that produce pathogenic antibodies. By more selectively eliminating these long-lived plasma cells, these therapies aim to achieve deeper and more durable disease control than currently available treatments. Alright, as promised, here is that summary frame again, and you can also download this from the video description below. Comprehensive and individualized treatment selection, adherence to monitoring protocols, and prompt management of relapses are key to minimizing NMO-related disability and improving outcomes. We are just starting this channel, so your recommendations on how to improve future lectures will be highly appreciated. If you found this helpful, please subscribe and hit the notification bell. Leave your suggestions and questions in the comments. Thanks for watching.